Well, I think it's fair to say that with the increase in cases comes increasing fear, but COVID-19 has a low mortality rate, and is the panic therefore warranted? To help us unpack this now, we are joined by Professor Shabir Madhi, who is a vaccinologist from WITS University. Professor, good evening to you and welcome. You were watching the footage through from Geneva with us moments ago when the World Health Organization declared this a pandemic over an epidemic. Maybe that's a good place to start and just get your response to that.
So, Jeremy, I think this discussion has been in the public domain for the past few weeks as to whether we were already existing in a context of a pandemic. And the reality is that since the spread of the virus beyond the Chinese borders, including widespread, especially in Iran as well, especially in Italy, it already lives up to the definition of a pandemic, which is more than one region of the world has been affected with widespread community transmission of this particular virus in this instance. So we've been living under a pandemic context for the past few weeks already, and it's just a matter of the WHO now confirming based on their own assessment of the situation, that we are in a pandemic situation.
Again, the WHO also saying that they're not going to be shifting at this point from containment to mitigation, but containment remains a major pillar. Are you able to tell me what the difference between those two?
Correct. So what containment really is referring to is to try to optimize or to minimize the transmission of the virus in a community. And as an example, what happened in China, what's happening right now in Italy is a complete lockdown of the country. And it's sort of what we call social distancing as well, where individuals that are likely to be infected, to try to keep them apart from other individuals and hence limit the spread of the virus to become much more widespread. So that's what containment is all about, is to try to still mitigate widespread transmission of the virus. So that's what we're still aiming for. It's worked in China, it's worked in Wuhan. As you're probably aware, they've lifted the restrictions in terms of mobility in Wuhan itself. Italy obviously is an early stage of its lockdown. Now, whether lockdowns would actually be successful in a context of low middle-income countries and resource-constrained countries is a completely different discussion. And there's skepticism as to whether you could lock down a country such as South Africa and many other sub-Saharan African countries where the dependency on earning a living day by day is much more.
So if we couldn't implement a lockdown then, should this escalate, would the consequences be more catastrophic for us?
Unfortunately, it would mean much more disseminated transmission of the virus, which means a higher percentage of the population would become infected than compared to China. So just as an example, in Wuhan, the number of individuals that have been infected by the virus, that have developed COVID-19, the illness, is roughly about 6 per thousand of the population. Okay, the number of individuals that have developed severe disease in Wuhan is about 1 per thousand. The number of people that have died in Wuhan is about 24 per 100,000. Right? But now that is under the context of having implemented the lockdown. Had that lockdown not been implemented, those numbers would have changed dramatically. The number of people that would have developed severe illness wouldn't have been 6 per thousand, it would have been much more. And I think that's a situation that we're facing right now. That's a threat that we're facing, is that should there be community transmission of the virus in South Africa, and it's unlikely that we're going to be able to implement a lockdown, those numbers in South Africa are going to be much higher. And unfortunately, in a South African context, we got more of what we call comorbidities, which increases the susceptibility of individuals to develop more severe disease.
So we're talking here about HIV and tuberculosis.
Unfortunately, those two in particular, including a high burden of non-communicable diseases of individuals that got chronic heart problems, chronic lung problems. But the unknown factor is the whole issue of individuals with HIV and TB. Let's remember, roughly about 6 million people in South Africa have got HIV, 6 to 7 million. That's a large percentage of our population. In terms of what we know about this virus, what we call a case fatality risk, the risk of someone that develops an illness to dying, for the general population is roughly about 1 to 3%, depending which setting. But if someone is over the age of 75, that risk increases to 14%. If someone has got a heart condition, that risk is 10%. If someone has got chronic lung problems, that risk is 7%. So that's a far cry from the 1% for the general population.
And we don't know then what that mortality rate percentages for South Africa?
For HIV and TB, we're completely clueless. But we can get some cues in terms of our experience with seasonal influenza. So with seasonal influenza, as an example, the risk of an HIV-infected individual that's on antiretrovirals dying is 40 times greater than the risk of someone that doesn't have HIV, 40 times greater, even when they're getting antiretrovirals. So knowing what we know about seasonal flu, knowing what we know about other bacterial infections that disproportionately affect HIV-infected individuals, even when they're on antiretrovirals, there is concern in terms of how they will tolerate an infection with the SARS coronavirus 2.
Professor, given those variables then that you've pointed out, the current strategy that South Africa is employing, is that sufficient? Or does it need to be recalibrated in some way?
Okay, it's sufficient in the context of doing contact tracing of known cases. But let's remember the individuals, those 13 individuals that have been identified, doesn't necessarily represent the full magnitude of individuals that have come into the country that have possibly been infected. Many of them might not even have sought medical attention. So we're really looking at a very biased group up to now that have actually presented themselves to be tested. Right, so there's sort of hidden issues in terms of the true numbers that might have been infected that have come into the country. So that's the first point. Now, the issue is, in terms of containment, with the current strategy, we need to do the contact tracing of those individuals that are known to be infected. But what you also need to do, and what is being done right now by the NICD as well as other groups, is to have a lower threshold for investigating for individuals that might be infected. And what I'm really referring to is to do a much more systematic sampling, irrespective of travel history, of individuals that are presenting with severe pneumonia, as an example. Right? And that will give us a sense as to whether there are any cases that are occurring in a general population that's due to this virus. So we need to sort of change our surveillance and have a lower threshold for investigating so that we can detect community transmission and community acquisition of the virus at a much earlier stage.
And if I'm hearing you correctly, we would need to start doing that sooner rather than later.
So it's already started. So the NICD, through one of its programs, my own research unit at Krasani Bergwana's Hospital, have already started that process, where we're going to be much more systematic in terms of screening, irrespective of a travel history, irrespective of a contact of someone that might have traveled to Europe or to China. If a person is admitted to severe pneumonia, we're wanting to actually test for this virus. We don't know whether we're going to find it or not. But it's better that we do it now than delay it to the point where we see a huge explosion of unexpected hospitalizations.
But in order to replicate that across the country, it would require greater capacity, and also it costs more.
Correct. So right now, the Medical Research Council is actually looking at developing some sort of a funding model to at least have some sentinel surveillance throughout the country, structured in a very similar way, where there's sort of non-biased screening of individuals that are being hospitalized for pneumonia to actually test for this particular virus.
Just a quick question, because we are out of time. We're into flu vaccination season now. Does that lower resistance to COVID, or does it help in any way?
Flu vaccination is not going to lower resistance to any infection. All it is going to do is that it's going to help protect individuals against influenza. Our big concern...
A particular strain. Yeah.
A particular strain, provided that the strains that are included in the vaccine matches with the circulating strain. My biggest concern right now is that in terms of the transmission of this virus, in terms of how it's moving across the globe, it might be that coronavirus really develops a firm footing in South Africa concurrently with when influenza virus is actually circulating. Where the co-infections between this virus in the same individual results in more severe disease is unknown. So we've got flu vaccines that are going to become available in the next 2 weeks. Individuals at high risk of developing severe flu disease are the same individuals at high risk of developing severe disease from the coronavirus. Those individuals should be prioritized for vaccination with flu, even if it's only to protect against flu, but it might have the added benefit of actually mitigating severe disease that might result because of co-infection with these viruses.